last makeup day for our RAMP Triage training. So we're going to get into this. If at any time you have any questions, please go ahead and stop me, whether it be in the chat or just shout at me with your audio. So this RAMP Triage system has replaced Start Triage. So Start Triage, I've never seen it used on an incident. The people that we've talked to who have actually used it say it didn't work as it was intended to, and that's to be expected, because if we're not practicing something on a regular basis, if we're not training on it, chances are we're not going to be good at it, especially when we have a large incident, right? What's nice about RAMP Triage, and we're going to talk about this, is you can truly use this on any size incident, right? Down to 2 patients, you can utilize the theory behind this, the data, the statistics behind this to truly analyze and triage your patients, right? Because what triage is trying to decide which patients need to go first. That is what truly a triage system is, and that's what RAMP Triage does, right? Whereas in the past, we really just looked at a patient and said, okay, you look really messed up, I'm going to make you an immediate. You look kind of messed up, I'm going to make you a delayed, right? So this truly gives us a way to analyze our patients. So this is kind of a refresher from the target solutions that went out. I'd just like to hit on this again, because this is the data, this is the science behind RAMP Triage. So what they did was they conducted a study. This study had almost 30,000 patients in it, and they looked at trauma patients, and they said, okay, how can we best gauge survivability for trauma patients? And what they found is that if a patient can follow basic commands and had a blood pressure of 100 systolic, their mortality rate was extremely low, right? As you see there, mortality rate of less than 1%. Casualties who could either follow basic commands or had a blood pressure of 100 systolic, so one but not both, that's when their mortality rate started to increase. And then if they had neither one of those, they're not following basic commands, and they did not have a blood pressure of 100 systolic, that's when the mortality rate starts to rise significantly, right? So they looked at these numbers, these statistics, and they said, okay, based off of these numbers, how can we create a triage system that is truly based off of the survivability of the patient, right? And that's where RAMP was created, Rapid Assessment of Mental Status and Pulse. Now, the best way to gauge a patient's mental status is to gauge their GCS, right? But the problem is they found that healthcare providers are not good at just looking at a patient and scoring an accurate GCS. And I'll be the first to admit, that when I do a GCS, if it's somebody that's really altered, I have to look at the Zoe and be like, okay, flexion, extension, 3, 4, whatever the case may be, right? So they said, okay, what's a good substitute for that? And a good substitute for that would be, do you follow basic commands, right? So that's what they went with. And then as of with blood pressure, right, 100 systolic was that magic number. We're not going to get blood pressures on patients when we're trying to get a rapid triage. So the substitute there was, do you have a radial pulse? Because pretty much all the data that we look at says that if you have a radial pulse, your blood pressure is generally at least 90 systolic, right, which puts us right in that 100 systolic range. Right? So you see, if your patient is following basic commands and has a radial pulse, that patient has a 95% survival rate, right? Versus if they have neither one of those, no radial pulse, not following basic commands, they have a 92% mortality rate or a significantly decreased survival rate, right? And then you also see here, if at any time your patient becomes hypotensive, your trauma patient becomes hypotensive, their mortality rate jumps up greater than 50%, right? So again, this system is truly based off of a survivability profile to make sure that we get the resources to the patients that absolutely need them first. So here is your RAMP triage chart, and this is in Karam's. It is in there today. So basically we come through here, patients without obvious signs of death, right? So those signs of death that, we safely say, if you see these as a paramedic, you can say this patient is deceased, right? Decapitation, 3rd-degree burns to 90% of the body, transection of the torso, right? Those are all safe to say that person has expired. If they do not have those obvious signs of death, they go through this chart, right? Do you follow basic commands? Well, yes, you do. Okay, let's check your radial pulse. They have a radial pulse. They have a 95% survival rate. That's a delayed patient, right? Go through again. If you follow basic commands, but you do not have a radial pulse, that's an immediate patient. They don't follow commands, right? Because they're altered, but they still have a decent blood pressure. They still have a radial pulse. That's an immediate patient. Not following commands, no radial pulse. That patient is classified as dead and dying, right? So before we get the question, this is being used valley-wide. This went through the EMS ROC committee. Every city is using this triage system. So the question always comes up, do you really want me to use the term dead and dying? That is what they decided. We will classify patients as dead and dying. We couldn't even change this if we wanted to. We try to tweak a few things for this training. But again, this is valley-wide, so we've all got to play by the same system, right? So those are your classifications. If we look up here, so nonverbal patients, right? So you have a child who's not of speaking age yet, maybe they're too afraid to speak, or you have an adult with some type of developmental disabilities, you can utilize the AVPU system, right? So for those patients, if they're alert or alert to verbal stimuli, that would be a yes for follows basic commands. If they're alert to only painful stimuli or unresponsive, that would be a no, okay? But we only want to utilize that for those children and those adults with developmental disabilities, because it's not the best way to gauge their mental status, right? The best way is GCS. We've talked about the challenges with that. The next best way is do you follow basic commands? Third best way for those patients, we can't really judge it based off following commands because of either their age or any disabilities. That's when we use the AVPU. Off to the side here, you see involved needs assessment. That replaced involved not injured, so there is no more involved not injured. There is no more minor category, right? It is involved needs assessment. We want to reserve those for those patients that we get on scene, we walk up to them, they're already on the phone with their insurance company. They're like, yeah, I'm fine. You know, I don't want your assistance. Okay, we can classify that patient as an INA. The thing about INAs is before we clear the scene, we want to circle back to them. Hey, are you sure that you don't need any assistance? You sure you don't want to be checked out, go to the hospital, whatever the case may be? We do not have to do a refusal on all of those patients. We just want to follow up with them again before we leave the scene. Now, if you have a patient that's telling you they don't want your assistance, but you can see some kind of an obvious injury, right? They've got blood, kind of, going down their head, or they've got a big hematoma, or they've got some significant road rash, and they're like, no, I don't want your help. Tend more to put that patient in the delayed category, because you can see an actual injury and you're going to want to address that patient, especially before, again, the guy that's on the phone with their insurance company or whatnot. So we kind of keep that INAs for people that don't want your assistance and have no visible significant injury. This life-saving interventions tab up here. So what that is if I'm going to do a triage and I come up on a person and they have an immediate life-threatening injury, right, that I can immediately provide a life-saving intervention for, I don't just want to walk away from that patient, right? I want to address the immediate life threat. Now, I'm not going to focus in on that patient because I still have to complete the triage, right? That's vital, because this whole event is kind of waiting for that triage so that command can start to build it, right? So the only thing that we would treat when immediate life threat would be, the biggest one would be a life-threatening bleed, which we're going to place a tourniquet for. Where it says open the airway, that's just very simply going to be, maybe, I'll roll that patient into the recovery position. We're not going to drop any type of airway adjunct. We're not going to give any type of breaths. We're just going to kind of roll you in a position to hopefully keep your airway open. The only other intervention we may provide would be a needle decompression, right? Let's say you have a patient with a gunshot wound to the chest. You walk up and they're kind of like, I can't breathe, right? That's a patient we may say, okay, you know what? I'm going to perform a quick needle decompression and then I'm going to move on, right? We're not going to focus in. So you place a tourniquet, possibly drop a needle, and then that's it. You're moving on to your next patient so that you can complete that triage, right? One way that people have been able to kind of pick this up is okay, what are we assessing, right? We're assessing, do you follow basic commands? Do you have a radial pulse? Two things, right? You get a point for everything you have, right? If you have both, you're following basic commands, you get 1 point. It's a yes. You have a radial pulse, right? Yes, you get a second point for that. 2 points, you're a delayed. If I only have 1 point, that's an immediate, right? Do you follow basic commands? Yes, you do, 1 point, but you don't have a radial pulse, so you have 1 point, right? Immediate. Same thing if you go the other way. If you have 0 points, right? Not following basic commands, no points, no radial pulse, no points, 0 points is dead and dying, right? Now these dead and dying patients, we are not writing them off, right? It is just that they are last in the order of treatment, right? We need to get resources other places first, right? We will absolutely address dead and dying patients, patients like trauma codes, if we have the resources for it, right? So our routine MMVA, where we have a trauma code, right? We're not just going to leave that patient there. We're gonna manage the scene, and we're gonna get the resources to who needs them first, and then when it's appropriate, we'll get them to those dead and dying patients. And we'll talk a little bit more about that as we go forward. Any questions on this? All right, let's keep moving. All right, so the way it's going to work, your initial triage, right? Same way, we're going to send somebody out to get a triage. They're going to rapidly move through. They're going to assess their vital status and their pulse. They're going to apply any immediate life threats as you see them. After that, those patients will get funneled to the treatment sector. In treatment sector, they will get a full trauma assessment, okay? We can continuously monitor their RAMP status to see how they're doing. And the big thing is ultimately with treatment sector, we're going to have to find out how many trauma alerts we have. Okay, so this is a big element. This is a kind of the biggest change for us is, let me back up here a couple slides, right? If we look out of these 30,000 patients, right, we see the study, 29,500, right? 87% of those patients could follow basic commands and had a radial pulse. And which category would those patients fall into? Follow basic commands and had a radial pulse. That would be the delayed category. We are going to have a lot more delayed patients, okay? And that's okay, because now we're truly getting the resources to those patients that truly need it first, based off of survivability profile. Now, just because somebody is a delayed patient does not mean that they do not have to go to a trauma center, right? They absolutely could fit trauma criteria, which the next slide is going to go over some of that trauma criteria, right? They still need to go to Banner Desert, to Osborne, whatever the case may be. But the thing is, their survivability profile is high, right? Because they're following basic commands, they have a radial pulse. So we just need to send patients ahead of them, right? But with that being said, it is very important that we identify those delayed patients that still are trauma alert patients, right? We want to find that out as soon as possible, because that way command can again start building that event better, right? They know, okay, I've got, 3 delayed patients that are still traumas that still need to go to desert. They're going to get their own crew. I need to have ambulance for those patients. So the earliest I can get that information, the better. So if you're given a triage report and you identify that, hey, I've got 4 delayed patients, but 2 of them are trauma alerts. Relay that information to command in your triage report, right? Now, ultimately, the last line of defense is treatment sector. So if you're a treatment sector officer, you need to rapidly identify those delayed trauma alerts, right? Immediates will always be trauma alerts. That's easy. Specifically, those delayed trauma alert patients, relay that to command so they can start building that event. What we don't want, and what we have done in the past is, oh, you need to go to a trauma center. I'm going to make you an immediate patient, right? That defeats the purpose of triage. Triage is not designed for resource allocation. Triage is not designed for destination determination. A triage system is designed for who goes first. That's it. And then we build that event based off of the triage report, right? So we don't want that. We don't want somebody just saying, hey, you need to go to a trauma center. I'm going to make you an immediate. No, they're a delayed, but they're a delayed trauma alert patient, right? And that's where the third category comes in, hospital notification. You're very simply going to say, I have a trauma alert. They don't understand immediate or delayed, just like we really don't understand trauma yellow, trauma green, trauma red. So you're just going to say, hey, I have a trauma alert, and then give a rundown of your patient. Here is your trauma criteria, and this is in CARMS, okay? So you can look at this, and you absolutely see that there are things in our trauma criteria that is very reasonable to think that patient is still going to be following basic commands, and they still have a radial pulse, right? They're a delayed patient, but they're still a trauma alert, right? We see things like, you know, long bone fractures, pelvic fractures, certain falls, you know, certain high-risk auto accidents, right? Those patients absolutely can fall into the delayed category, right? And we want to put them there, and then again, just make sure that we identify that they're a trauma alert. We're actually setting up third quarter EMS training right now, and we want to kind of reinforce this stuff. And we look back to 2019, and we actually found a call. It was a mother with 2 children trying to cross the street. They were struck by a vehicle. All 3 of them were struck. It was a very chaotic scene to the point where when you listen to the audio, it's one of those ones where you're hearing people scream in the background, right? It's a bad scene. Crew comes in, they made all 3 patients immediates, right? Which, you know, they're operating, you know, 2019, our old triage system, right? When we look back at the charts, we pulled the charts, we reached out to Banner Desert to get, you know, some follow-up on these patients. And what we found was, out of those 3 patients, if we had utilized RAMP Triage with these patients, right? So this is a smaller event. This is not a mass casualty event, right? This is a 3-patient event. The mother was A&O times 4, and her blood pressure was listed as like 130s over 80s, right? So very reasonably to think that she has a radial pulse, right? She would have been delayed. Second child was acting appropriately for their age, strong cry, screaming, right? So again, because they were so small, under 2 years old, if we would have utilized AVPU, you know, they're alert, how they should be for their age. They actually got a blood pressure on that kid, which is great. We really want to emphasize, please get blood pressures on kids. Their blood pressure was good. So again, reasonable to think they would have had a good, strong radial pulse based off their blood pressure. That second kid would have been delayed. Third kid, the kid that was in a stroller was actually thrown up onto the hood of the car. That patient was, how it's described in the narrative, was not responding to painful stimuli, right? So if we look at AVPU, that's a no under follows basic commands. Again, good on this crew. They got blood pressures on that kid as well. Their pressure was around 110 systolic, right? And we talk about kids, 70 plus 2 times the age in years. That's a great blood pressure for a kid, right? And again, RAMP, when we're looking at blood pressures, you know, reasonable to think, again, they had a good, strong pulse, right? That would have been an immediate patient, right? So that's what's good about this system, is because with this system, that truly critical kid is going to go first because they're the immediate, right? The other 2 were delays, right? So the first crew that comes in, the first ambulance, hey, you're taking that kid. Versus if we just make them all 3 immediates because it's a horrific scene, because they still all need to go to desert, right? They were still all trauma alerts. We create a scenario where we're giving resources to patients in the wrong order, right? We have more critical patients that are waiting on a crew, waiting on an ambulance, right? So again, that's the whole thing behind this system. For those pediatric patients, they still do want you to assess the radial pulse. This was absolutely discussed with all the hospitals. So if you hear anything different, that's wrong. We met with the hospitals, specifically Phoenix Children's. They're the ones that came up with, hey, use AVPU for kids. They also said still check for a radial pulse. If the kid's so small that you can't find a radial pulse, you can defer to brachial, but they still want you to try to get a radial pulse with these kids. We talked about that patient getting a full trauma assessment in treatment sector. Remember, RAMP is nice because it gives me a snapshot throughout that entire event, the entire time I have that patient. It's like a continual evaluation, right? You're following my commands, you've got a good pulse. All of a sudden, if I notice something changes, right, based off of RAMP, right? Maybe when you came in, you're following basic commands, you had a radial pulse. Next thing I know, you're starting to become altered. I reassessed you, you're not following my commands, but you still have a radial pulse, which is extremely quick to assess. Oh, now you're an immediate patient. I need to update command or treatment sector. Hey, my delayed patient is now an immediate, right? We talked about communicating with the hospitals with trauma alert. That's what they're expecting to hear. Your order of treatment, immediate, delayed, dead and dying, INA, right? Now, there is critical thinking that comes into this here, okay? Now, first, we can kind of even break this down further, right? Order of treatment should be immediates, and then delayeds that are trauma alerts, then the rest of delayeds, right? And then everybody else, so we can even kind of delineate delayed with a trauma, delayed without a trauma versus who goes first. But can I come up with a scenario where I'm going to assign the next crew to a dead and dying patient over a delayed patient? I can, right? We can what if things all day, right? If I've got two patients, right? One's laying in the street, they're a trauma code. The other patient has a full thickness laceration to their arm, right? Needs to go to the hospital, needs to get stitches, right? But bleeding's controlled. They're following my commands. They have a radial pulse, right? No, I do not expect you to start wrapping that person's arm with cling while somebody's laying dead and dying in the street, right? We've got other crews coming, right? Absolutely, you can say, you know what, take that trauma alert. That delayed patient can wait just a couple minutes for the next crew to come in, right? I absolutely can come up with scenarios where that would come into play, right? Now, on a big event, right, we want to stick to this, you know, immediates first, then delayeds, right, then dying, because that's what's great about this system is I can truly use it on small events, 2-3 patients, and I absolutely can use it on a very large event with multiple patients, right, because it's very easy to assess these things. So does anybody have any questions on anything that we've covered up to this point? I hear somebody with their microphone on. Does anybody have any questions? You just want to talk about what that means?
Oh, just at some point, guys, when you do make those trauma notifications, those trauma alerts, just to keep things clean, make sure you drop them down in the Zoe drop down as a trauma alert. That's how the state and all the data is analyzed. So if you just put a trauma alert in your narrative, but don't do it in the drop downs, we missed that piece of data for how many traumas were going on and sent to the hospital and such. Thank you.
All righty. All right, so this is our interactive portion of the training. So either get your keyboard to be able to type in the chat box, or you know, figure out how to work your microphone, because we're just going to go down the list of people that are in this training. I'm going to give you a patient, and then you're going to tell me, you're going to triage them, right? So you're going to tell me what category they're in. So the first person listed here is actually a phone number, 735-8341. So whoever that is, you get the first patient. Here you go. Your patient, you have a 45-year-old male with an obvious head injury. They are able to communicate the event to you, right? They're talking to you, answering their questions, and they have a radial pulse. So what would you triage that patient as?
And who are you so I can get you on the roster?
That too. Will you say your name so we can get you on the roster? 735-8341. Maybe they just dialed in, they're doing yard work or something. I don't know. All right, we're gonna move on. We'll come back to you. All right, Mr. Tony Lopez, what would you triage that patient as?
This would be a delayed patient.
Perfect. All right. Mr. Ramirez, you're next. 37-year-old female, compound fracture to the left tib fib. She is following your commands and has a radial pulse. when you're at work. Armando. Delayed, there we go, he's in the chat, thank you. And then also, we're talking about, fractures and whatnot. This patient could also be a trauma alert. Did somebody have their hand up? Mr. Tobin, do you have a question?
I do. So on the first patient, wouldn't that be a trauma alert as well? Obvious head injury?
Could be, yeah, absolutely. It kind of depends on if they had, just a small cut above their eye versus a hematoma. You absolutely could put that patient in the trauma alert okay. Category. Yep. All right, so we got Mr. Hayes is up next. 25-year-old male struck by a vehicle. He is awake, right? But he's unable to answer your questions, and they have a radial pulse.
Immediate?
There you go, immediate. And then all immediates to get our trauma alerts. Good. All right, Mr. Moffitt. 17-year-old female is unresponsive, but still has a radial pulse.
Immediate?
There we go. Good. Immediate. Perfect.
Man, winner, chicken dinner.
All right. Mr. Allred. 55-year-old female is lethargic following a head strike. So she got her bell rung, right? But she is still able to communicate with you. She's answering your questions. She squeezes your hand when you ask her to, and she still has a radial pulse.
I'm going to say delayed.
There we go, right? And then again, especially when we get older in age with the head strike, we consider a trauma alert with that patient as well. Good. All right, Mr. Forward. 2-year-old male was involved in a rollover. They were restrained in a car seat. They are crying loudly, acting appropriate for their age, good signs of perfusion, and they have that radial pulse.
So he's going to be a delayed, and I'm going to consider a trauma alert, but I'm going to need a little more assessment.
Right. Yeah, good. Perfect. All right, Mr. Tobin. 26-year-old male with a GSW has a large amount of bright red bleeding to their left leg. They're awake and answering questions, but they do not have a radial pulse.
I'm going to apply a tourniquet and they're immediate with the trauma alert.
Boom. Got it. Good job. All right, Mr. Hyde. 35-year-old female was involved in an MMVA. They have no apparent injury. They're stating they're fine and they do not want your assessment. Justin Hyde.
INA.
Huh? Did he say it? Oh. All right, Hyde, we're going to come back to you, buddy. But yes, that is an INA patient, right? All right, station 214, you guys are up next. We'll give you a couple because you got a couple people there. 19-year-old male was thrown from the bed of a pickup truck. He is unresponsive, but still has a radial pulse. See you guys. What you guys got? We're even ready. We're going to come back to you guys. Find your keyboard. Mr. Castaneda, what would you classify this person as? All right.
He put it in the chat, Luke.
There we go. There you go. Okay, we got it. Good. So immediate trauma alert. There we go. Good.
14 said.
Yeah, 14. 14, I'm going to give you another one. Here you go in the chat. 27-year-old male with significant road rash, right? So you walk up, they got road rash all up and down them from a motorcycle MVA. They're up and talking. They state that he is fine, does not want your assistance. They want you to check on their passenger. They're like, hey, check on my wife that's on the back of my vehicle. So 214. We're not hearing you because you're muted. they said INA. So with this patient, because they have that significant injury, right, that road rash that we're seeing, right, we're going to want to put them more in the delayed category.
There's Justin Hyde.
Justin Hyde's in too. Good, good. So 214, I'll give you one more. 30-year-old male at the scene of an MVA has no apparent injury. They're on the phone, states that they're fine, and they do not want your assistance. INA, good. And there's kind of the difference between the two. So they're both telling you they don't want your assistance. This motorcycle guy, I see a significant injury. The other patient, I do not, right? So good job. All right, so good. So Hyde, I'll give you this next one. I see you're on the chat here. All right. So 22-year-old female was unrestrained in a rollover. She is unresponsive with a radial pulse. Immediate, perfect. You see Justin Rosales is in there.
Yeah. Got him.
All right, let's see who's next here. Michael Johnson, you're up next. 20-year-old nonverbal male with developmental disabilities is awake and is alert to verbal commands, and they have a radial pulse. All right, chat, delayed, good. All right, who's up next? Richard Harp. 47-year-old female was on a bus involved in an MVA. She states she's fine and she has no apparent injuries.
INA. Say
INA.
I don't say INA.
All righty, good. Mr. Baldwin, 38-year-old female, laceration to her left arm following an MVA. Bleeding is controlled. She insists that she's fine. She still has a radial pulse distal to her laceration. All right, delayed. There we go. Perfect. All right, back up to the top. Mr. Lopez, you have a 40-year-old male with multiple gunshot wounds. He is awake and following your commands, but he has no radial pulse. What you got, Tony? There you go. It's immediate patient. All right, next one. 29-year-old male has a GSW to the right upper arm. You notice a life-threatening bleed. They're following commands and have a radial pulse. So Armando, this one's yours. All right, anybody?
I'll do it.
They're
It's
delayed.
immediate with a tourniquet.
So this one's actually going to be delayed, right? Still following commands, has a radial pulse, right? So we'll get that tourniquet on, and if we can stop that bleeding before anything else changes, that'll still be a delayed patient, right? All right, Chris Hayes, 3-year-old female who was involved in an MVA. There were other significant injuries in the same vehicle. She is refusing to speak to you, but is following verbal commands and has a strong radial pulse. What do you got, Chris? All right, anybody?
Make her a delayed with trauma alert.
Okay, good, delayed. All right. All right, Chris, you ready for the next one?
Yes, sir.
40-year-old male is unresponsive with no radial pulse.
Dead dying.
Okay.
There we go, good. All right, Mr. Moffitt, you're up. 15-year-old female fell 20 feet following a bleacher collapse. She is unresponsive with a radial pulse.
Immediate.
Immediate, good. All right, so with this patient up top here, right, this GSW with a life-threatening bleed where they're delayed, what we found in the training is a lot of people kind of had a problem with that, right? Why is that patient not an immediate patient? They have a life-threatening bleed, right? And here's the thing, right? If we can stop that bleeding, right, which is why we want to put a tourniquet on and they still have a radial pulse, still following commands, they still have a very good survival rate, right? And we could specifically look at an incident like the Boston Marathon bombing, right? We looked at that for active shooter. In that event, there were about 20, I believe it was like 20 or so patients that had extremity hemorrhage, right? And about 10 of those patients were so badly injured that they had to have their limbs amputated, right? They were mangled limbs. But they lost 0 people from hemorrhage in Boston because they were so diligent with their tourniquets, right? So if we can stop that bleeding, right, that's the thing. And the reason they're delayed is because if I put that male with the GSW that I put a tourniquet on and I stop their bleeding next to this female down here who fell from the bleachers, right? She's unresponsive with a radial pulse. Here's the thing, who needs my next crew, right? Who needs the next ambulance? She would, right? And that's why that patient is a delayed, okay? Because again, all this is who goes first. They don't get any less treatment than anybody else, right? We're still going to throw a tourniquet on. They're still going to get a crew. They're still going to get transported to a trauma center. But the reason they're delayed is because other people need to go first, right? And that's why it's also important to identify delayed trauma alert, so that way that patient can go over the other delays as well. All right, Mr. Allred, 38-year-old female has significant injuries. She is extremely altered, but she's answering your questions. She squeezes your hand when you ask her to, but she has no radial pulse.
I'm going to say immediate.
Good. All right, forward. 27-year-old female is unresponsive with no radial pulse.
Me dead dying.
Go good. Mr. Hyde, 23-year-old nonverbal adult, is alert to painful stimuli only. She still has a radial pulse. Delayed trauma. And so with this one, so if we use that AVPU scale, right, painful stimuli only would be a no for our follows basic commands, and then they still have a radial pulse, so that would put them in the immediate category. All right, next patient. So ladder 214, you guys are up again. 21-year-old male with a GSW to the right arm, bleeding is controlled. They're following commands and have a radial pulse. And they say delayed trauma. Perfect. Good job. We'll give 214, we'll give you another one. 48-year-old female unresponsive with no radial pulse. Dead. Perfect. Good job. Castaneda, you're up next. And then after that, Michael Johnson, Richard Harp, and then Ryan Ballman. That's our order. So Castaneda, 49-year-old male with multiple injuries, is lethargic and extremely confused, right? So they're not answering your questions following commands. And they still have a radial pulse. Immediate. Perfect. Good. Next patient, and this is for Michael Johnson, 23-year-old male with a head injury, is not responding to you, still has a radial pulse. Chat, immediate, perfect, good. All right. And we got Richard Harp. 21-year-old female has bilateral compound leg fractures. She is responding and following your commands, and she has a radial pulse.
I believe that's delayed.
Delayed, right? And trauma because of those long bone fractures. Good. Mr. Ballman's up next. Then back up top, I believe it's Tony next. All right, bus rollover on the 6D. 50-year-old male has an obvious head injury. They're slow to respond. Again, they're still following your commands though, and they have a radial pulse. All right, so we got delayed trauma alerts. Good, perfect. All right, back up top, 25-year-old male was rear-ended trying to avoid the bus. They're walking around. They're like, I'm fine. I'm okay. Tony, what you got?
INA.
INA, good. All right, so we got Armando, Chris Hayes, Moffitt, all red coming up. So Armando, this one's yours. 23-year-old male is trapped. He is able to follow your commands, but does not have a radial pulse. All right, immediate, good. 1-year-old female is awake and crying loudly with a strong pulse. That's for Mr. Hayes.
Sorry. Delayed.
What you got? What you got, Chris?
Delayed.
Delayed, good, good. Especially with those, you know, anybody that small, nonverbal, can't really tell you where it hurts. If they're involved in some type of significant mechanism, we want to tend to make those, you know, delayed, right? So good job. Moffitt. 60-year-old male is not responding with no radial pulse. Good. All right, Mr. Allred again. 52-year-old female unconscious with a radial pulse.
Immediate trauma alert.
Boom. All right, forward Tobin High, 214. All right, so Mr. Tobin's, or sorry. Yeah, did we skip forward? No, forward, you're up. 40-year-old male is awake but cannot answer questions or follow commands, but they still have a radial pulse.
Immediate trauma alert.
Very good. All right, now we're on Mr. Tobin. 38-year-old female has third-degree burns to the left arm. She is screaming. She needs help and can answer questions, and she still has a radial pulse.
Delayed burn center alert.
Good. Perfect. All right, we're almost done, I promise you. All right, Mr. Hyde. 28-year-old male shot in the right leg. There's significant life-threatening bleeding. Patient is extremely altered, so they're not following your commands, and they do have a radial pulse still. Immediate. Good. Then we want to hit that tourniquet on that life-threatening bleed. Good. 26-year-old male with a GSW to the head, not responding, no pulse. This one is for 214. Oh yeah, we forgot about Mike. Mike gets the next one. Dead. Dead. All right, Mike, here you go. 29-year-old female shot in the shoulder, bleeding is controlled. She's able to answer questions and has a radial pulse. Delayed. Delayed, good. All right, who's next? Castaneda, 30-year-old male is shot in the chest. She's awake following your commands. They have a radial pulse, and they are complaining of severe respiratory distress. Delayed trauma alert, perfect. And then that's that patient. There you go, perfect. Good job. Needle decompression. We're going to consider that as well. Good job. All right, so this one, I would just want you to read through it, and then whoever has it first, go ahead and either type it or just shout it out for us. What we got?
Okay, I got a triage. So I have an INA of 1.
Okay.
Sorry, total of 6 patients. INA of 1. I have a delayed of 2 patients. I have 2 immediates and 1 obvious or 1 903.
Boom, there we go. Good. So 2 immediates, 2 delayed, 1 INA, 1 den dying. We do want to get away from the 9 codes. And we have asked that. Other people have asked the question of what do we call them when they do have obvious signs of death, right? So as of right now, just call them dead and dying. We'll probably get a better answer for that, but we do want to stick away from the 903 codes. But good job. One of the big reasons we put this in here is just kind of a reminder. So if you're not aware, there are new triage bags on your truck. They've been there for a while. Not everybody's aware that they're there. We replaced the start triage bags. In that bag, there are ribbons that you can tie onto patients. There's a ribbon for all the colors, especially in the event that we had a large event where we had to actually send extrication teams in. They could look for all the red tape first, then the yellow. But what that kit also has, in the front, there's a clear pouch. Inside that clear pouch are cards. Those cards are not for the patients. Those cards are for you. And they break down each category. There's even a spot there for a writing utensil, so that way you can pull that card. And as you're walking through this event, you can just kind of quickly tally how many of each patient you have. All right, last slide, then we're done. And just anybody shout this out when we have it, right? So you're in the treatment sector, seen with multiple patients. You've been given a patient that was classified as delayed. The patient has a hematoma to their head, multiple abrasions. Initially, they're following commands and they have a radial pulse. While you're treating the patient, they begin to appear altered. You reassess their RAMP status, and now the patient is not following your commands, but still has a radial pulse. What is your next course of action in addition to continue treating the patient?
Upgrade them to an immediate.
There we go, right? So that's one where either you let treatment sector know, treatment sector lets command know. You know, I have a delayed patient that was now an immediate, right? That's where our updated triage comes into play. Okay. That's all I have. You know, this is a really good system. We can, you know, start using it today. The neighboring cities are going to be using this as well. And again, you can truly use this on any event, big or small. And the more we can use this and understand the principles behind it on the smaller calls, if we do ever have that big event, we're going to be, it's going to go much better, right? So we encourage everybody to please utilize this on all events. That's all I have for you. Again, if just make sure that if you were on a computer with somebody else, your name gets over somewhere in the chat area so we get credit for you. If you have any other questions, please feel free to reach out to me or anybody from EMS. But that's all I have for you. Thanks for coming by. There you go.